So Mo, the next thing I want to talk about is the new Q. Dave, how long have you been here?
Well, I've been here the whole time, Scott. Thanks for noticing.
Oh, okay, well, sorry about that. Well, I guess, Dave, would you like to kind of talk about the new Q-SOFA score and how it relates to Sears?
Sure. So we've changed up the sepsis protocol a little bit. So I stood up in front of all of you earlier this year talking about sepsis, talking about recognizing sepsis, and we talked about one of the assessment criteria being SIRS. Well, we're changing that up a little bit, and I'll give you a little bit of a historical background. But essentially, Q-SOFA is going to be a component of three different things. We're looking at altered mental status, so that's the GCS below 15. We're looking at blood pressure, a systolic blood pressure below 100, and we're also looking at a respiratory rate of greater than 22. So it's simplified it a little bit, and again, a little bit of a historical background on this. So there was a task force that was convened about 25 years ago to define sepsis and come up with some of the criteria to assess sepsis, because really it's a difficult process to assess. There's really no one specific test for sepsis, so that makes it difficult. And we stayed with these definitions and the SIRS for about 22 years, and then a few years ago they reconvened and said, SIRS really isn't a very good criteria. It is it's not specific for sepsis. It's catching a lot of patients, but it's not specifically for sepsis. And so that's when they developed what they called the SOFA score. So it looked at several different systems, body systems, and it was fine, except it wasn't really tailored to the pre-hospital setting. There were a lot of lab values that were entailed in the SOFA score, and so what came out of that was the Q-SOFA, so that's a quick SOFA. So SOFA stands for sepsis-related organ failure assessment. Blood pressure, altered mental status, and respiratory rate. And so those are the three different things we're looking at. So you're getting a score of either 1 or 0, 1, 2, or 3. So a score of 2 or higher, so if they meet 2 or more of those three criteria, then that is showing that they're more prevalent case of sepsis, and these are the more serious sepsis patients and the sicker patients.
Right, so the main thing to remember is first you must suspect infection. So either they've got some sort of respiratory or urinary or skin, those are the common ones. Potentially meningitis is another one, or if they have a central line, that's another site of infection that people often get, or if they have an indwelling Foley or some sort of indwelling device of some sort. So you've got to think that infection might be at play here, and then they meet the Q-SOFA score. So if they have a blood pressure less than 100, they have a respiratory rate greater than 22, or they have altered mentation of any kind, basically defined usually as a GCS less than 15, then basically that's a positive Q-SOFA score. So a positive Q-SOFA score, suspected infection, that should lead to a sepsis alert at the hospitals, and that's kind of what the new protocol talks about. The other thing that's in the protocol that's still there from before is those of you who use lactate meters. Go ahead and do your lactate, and if it's greater than 4, mention that in your sepsis alert. We realize that not everybody has lactate meters, so the Q-SOFA score / sepsis alert can be done on anybody, but the lactate is an additional factor. Then number 4 is really important, because it's been shown that if you have a level of 4 and if it persists above 4, that's actually a marker of high mortality in sepsis, and sepsis is becoming a major player. So we're doing this to help you do two things. One, recognize sepsis yourselves. Secondly, alert the hospitals so that if they want, they can go ahead and activate their internal sepsis protocols. Sepsis management is now a quality measure through CMS, which is how hospitals get reimbursed for at least Medicare and Medicaid patients. And so they're performance-based criteria. And so when you give them a heads up, hopefully they're getting their system in place so that when you arrive, they can actually aggressively resuscitate. Things to think about in sepsis, always remember is that you want to be thinking about fluids, you want to be thinking about pressors. We don't currently have antibiotics, and then lastly, you want to be thinking about respiratory support. So, be thinking about, again, all those components of our sepsis protocol. So think through that when you're managing these patients.
We had another line in there too about mean arterial pressure, and you're going to see that I think in a couple different places throughout the new protocols. Yep. Talking about targeting a MAP to 65 or greater on these sepsis patients.
So 65 is a good number to remember. Almost any patient, you want your MAPs to be 65 and higher. So very good point.
And I just wanted to clarify on the sepsis alerts. People are accustomed to like STEMI alerts that we're making. It's not quite the same thing. Basically, we're giving the hospital a heads up saying we have a suspected sepsis patient coming in, and that kind of triggers them to start their protocol. Is that correct?
Yeah, I mean, I think it's going to vary from institution to institution, but I think the idea, for example, if you are coming up to us at OHSU and you say you have a sepsis alert coming in with a lactate of 4.5, we're going to be activating one of our resuscitation rooms. We're going to basically prepare to receive that patient, and we're going to work on our checklist of things, which is to give them a fluid bolus. Usually they get 30 cc's per kilo, so about 2 liters of fluid. They usually go to pressors pretty early if they're not responding. We add high, broad spectrum antibiotics, and then we'll also potentially intubate them, and there's a bunch of things we do. So there's a checklist of things we go through very quickly in our sepsis protocol, and the idea is to help the hospital get this trigger early. Again, QSOFA is better than the SIRS criteria. The downside to the SIRS criteria is that you could get SIRS from anything. So a traumatic injury could basically give you a high respiratory rate and a high tachycardia, and that would then trigger potentially. So the SIRS criteria itself were kind of loose and were not very specific. These are a little bit more specific. And again, respiratory rate greater than 22, blood pressure less than 100, and then augmentation are the three key components.
With a suspected infection.
With a suspected infection.
Right. So keep looking for sepsis. It's more common than you might think out there.
Absolutely. Last thing we want to talk about is just a change to the respiratory distress protocol, which really isn't much of a change. It's now, there's permissive language to the addition of duodotes, which is your albuterol and ipratropium together. So that will be the first line agent. After 2 doses, then if you want to continue to use a bronchodilator, you'll just stick with albuterol only.
Right, so before we used to have you start with albuterol and then add the Atrovent, but now we're basically going to allow you to put the 2 up front, so you get a duoneb and then you get another duoneb, and at that point if you need more nebs then you basically switch just to albuterol. The Atrovent really only contributes value in the first 2 doses, and it only really contributes value in a select portion of patients who are what we call anticholinergic responsive. So not everybody with asthma or COPD will be anticholinergic responsive, but since we can't figure that out with some sort of screening criteria, we're just going to give everybody those 2 up front, and then we can switch off once you get past those 2.
Okay, very good. Well, thank you guys for helping out, and if you have any questions, contact your agency training officers, and we'll see you next time.
Thank you.